Hi, this is Dr. Howard Pecker, and I'm narrating an arthroscopy that we did recently. This is the medial compartment of the knee, which means the inside of the knee, and it's a left knee. And what you're looking at is damage that's done to the cartilage surface of the knee. That roughened, almost pinkish area above is the loss of the hyaline cartilage that coats the bone. And the cartilage has been lost and damaged because of a torn meniscus. This is a woman of about 50 years old who tore her meniscus about a year ago but didn't want to have surgery on it, and had an initial consultation, I believe. I don't know if she initially had x-rays at the time, but I know that she did not have an MRI. She could not remember if she had x-rays. And she did not want to tell me the doctor that she initially saw for her evaluation. But she was having continued pain now, and the pain was becoming more severe with time, probably partly because of this torn chunk that you see, this piece of meniscus that I'm holding forward to check the extent of the tear, and also because it had now degenerated her knee to the point that she was getting an arthritis. So the goal of the surgery will be to take away any unstable cartilage fragments so as to at least slow down the damage that is occurring inside her knee. Unfortunately, the damage to the cartilage that's on top of the bone cannot be reversed. We don't have the science for that yet. There are some types of cartilage replacement and grafting that are used, usually in the younger patient population. But they're more effective when the problem is more confined to a small area, when it's diffuse like that, especially when it's in the posterior aspect of the condyle, which this is. It's very difficult, if not impossible, to repair or rejuvenate. The good news is that with the large piece of torn meniscus taken out, she'll probably get a huge relief in her symptoms. Her knee won't feel unstable, like it's giving out. And there won't be anything else to abrade that area and rapidly degrade it. Also, the damage is more in the posterior portion of the condyle, which tends to come in contact with the knee when you're in flexion. So deep flexion activities such as climbing stairs, maybe riding a bicycle forcefully, will be more symptomatic for her than simple walking and standing. And fortunately, simple walking and standing is most of what we do. Getting up from a low seat or a chair might bother her sometimes because that's where her arthritis is. Now what you're seeing is little biting instruments. They have different types. They bite at different angles, brought in to remove these little pieces. We have to use these small instruments because the clearance inside the knee is very small. You've only got 4 or 5 millimeters, which is 1/5 of an inch, in order to get your instruments in, and you have to do it without scratching up the knee and causing further damage. The way that's done is the assistant is twisting the knee on the outside. You can't see it, and that opens up the space a little bit and puts a strain on the ligaments. And what you're seeing throughout the surgery is me taking small instruments that remove pieces. That one's a rotary shaver. It's a mechanical, it's motorized, and that little thing opens and closes. And here I'm just exploring to see how much more we have to remove, how unstable it is. And then continuing with the surgery little bit by bit to remove the pieces. Of course, it's unfortunate that she waited so long to have it taken care of. Had we taken out the meniscus last year when she first injured, she would probably not have all that damage she has in the back of her knee, all that irreversible damage. And I think she would have had a better knee in the long run. But it sometimes is hard to convince someone to do that. They're reluctant to have surgery. They want to try other things first, such as physical therapy or massage or other treatment modalities. But as you can see, the problem is that it was torn, and no kind of massage or manipulation or therapy is going to untear that piece. They never heal. The reason they never heal is because, unlike skin or muscle that has a blood supply, the cartilage does not have a blood supply. As you can see, there's nothing to stop bleeding here, but nothing is bleeding, and that's because there are no blood vessels in the tissue that I'm biting. These tissues survive strictly by diffusion of glucose and other nutrients in the joint fluid of the knee, and when they tear, that joint fluid coats all around them and prevents them from mating back to the surface next to them and healing. If you try and sew it, likewise, it won't heal. It's too degenerated, and it's too close to the inner rim to heal. In children, especially if it's an outer tear, you can often get it to heal, and I often do repair meniscus in a younger population. I've repaired meniscus in patients as old as 45 and 46 years old because the tear was way at the edge, and they were informed that we might try it, and they were willing to have a second procedure if it failed. And so far they've done very well, surprisingly well, if you pick the right patient. So we're just continuing little by little. We take a little bit out, we check it. We take a little bit out, we check it. Trimming a little bit of the loose cartilage that's on the femoral condyle. You don't really want to take more than you absolutely have to, because it degrades the surface, and we want to keep as much cartilage on there as we can, as long as it's viable cartilage. So at this point we've pretty much got the big piece out, and it's not likely to come forward and cause those same troubles anymore. But there are pieces in the back that look like they still might be a little unstable, so I'm probing it to see what would happen if we left it in, if it's likely to get pulled forward. And that piece looks good, it's nice and firm, but the piece in the middle looks like it's a bit loose, and so I think I probably took more of it just to ensure that it was at a point where it wouldn't get caught inside the knee and cause symptoms. And this is a very common injury. You can get it just from rising up from a low squatting position, looking for something under the kitchen sink cabinet, and getting up suddenly and feeling it. It can happen from sports and twisting, although that's much more common in the younger population, really under 20. In adult population, usually starting in the 30s and 40s, it happens from minor incidences and just from wear and tear. This patient will be allowed to walk right after surgery. After the surgery, I inject an anesthetic around the knee to give them some initial comfort, and often patients will just take maybe 1 or 2 pain pills, sometimes the night of the surgery when the anesthetic wears off a bit. But often they take nothing or just Tylenol. And the knee is sore, usually for a week or 2. But many people the next day go out and do a little bit of shopping, or just light activities. If they have a particularly strenuous job, or a job where there's no way for them to rest or take a break, sometimes they'll stay out 2 weeks. Some people who have to kneel constantly at work will stay out a full 4 weeks. But most of the time people get bored and they want to go back to work. So this just goes on, as we say, little by little. We don't rush, we take our time, want to make sure that it's resected to the point where it's safe, but that we leave as much cartilage behind as we can. Unfortunately, this tear goes quite far back, so we're having to remove quite a bit of the rim of the cartilage. Those little pieces that float away go out a drain that's in the upper knee. It's also why you see the tissues waving back and forth. The fluid is rushing through the knee through a separate drain that we turn on and off depending upon how clear the view is. MRIs have become an invaluable tool in detecting these preoperatively, and I would say they show 95% of significant tears. It's not always easy to tell the extent of the tear on the MRI because it does have its limitations, and these structures are very small even though they're very critical. That's a good view of how much damage was done to the knee from the torn cartilage. It's really taken off so much of the hyaline cartilage. The hyaline is the name of the cartilage that coats the bone. The meniscal cartilage is the one that we're resecting. They're both called cartilage, so that gives some extra confusion when people are having the procedure explained to them. And we're nearly at the end of the procedure here. Now that we've gotten all the unstable pieces, we're just doing some more survey of the knee. I think I turned off the recorder after this, but those torn fragments there are torn ACL, anterior cruciate ligament. That's a common sports injury in kids and in young adults. Usually when you get it when you're young, your knee is unstable and the ligament has to be replaced. It doesn't heal on its own, as you can see from this image. And in an older population, or really starting probably in the 40s, but certainly by the time we reach 50, our knees tend not to be so unstable when we have a torn ACL. That's the entire footprint of a torn ACL. She's had that stump in there for a long time. It may have occurred many years ago when she was young, or maybe last year when she tore the meniscus. It was a concomitant injury. And that's it. We're not going to replace it because she's not unstable. Thank you for watching.